Good evening, everyone. I'm Dr. Pratibha Singhal from Mumbai. And on behalf of CCI, it gives me great pleasure to be part of this third series in lung cancer, which is on diagnostic and management with advanced bronchoscopic techniques. Uh, CCI Con is round the corner. It will be held in Calcutta from 22nd to 24th August. Those of you who have not yet registered, please register immediately as the seats are filling out fast. You will have a great academic fest and ability to meet a lot of national faculties who are the best in what they do. So moving on with today's webinar, we have with us Dr. Aditya Chawla from Delhi, who is a young dynamic interventional pulmonologist, Dr. Rakesh Godara from Jaipur, Dr. Bala Raju T from Vishakapatnam. Incidentally, Bala Raju was also one of the first people to start radial EBUS procedures in South India. Dr. Jaykumar Mehta from Ahmedabad and Dr. Govind Desai from Hubli. They are all very dynamic people in the field of interventional pulmonology. We have 3 talks with us in the following series. Dr. Aditya Chawla will be speaking to us on linear EBUS and its role in lung cancer staging. Followed by Dr. Bala will be enlightening us on the role of radial EBUS in peripheral pulmonary lesions and cryobiopsy as an additional tool, followed lastly by Dr. Rakesh, who will be talking to us about rigid bronchoscopy and stenting in the management of lung cancer. After which we will have a panel discussion in which these 3 faculty will be joined by Dr. Jaykumar and Dr. Govind Desai. So over to you, Aditya, to start the first talk.
Good evening. So at the onset of my talk, I would like to thank Dr. N.H. Krishna, Dr. J. Chanam Chetty, Dr. Shivani Swami, and the entire CCI team for giving me this talk of linear EBUS and considering me for this panel discussion. So now we need to know why staging matters in cases of non-small cell lung carcinoma. We all know TNM staging, the 9th edition. It provides the anatomical details of the primary tumor, that is the size, the extent of the tumor, and the lymph node status, and the presence or absence of the metastasis. And this only guides us for the further treatment, whether the patient deserves surgery, or he only gets chemoradiotherapy, or only chemotherapy, or the combination of any. So how the sampling of medial cell lymph nodes is done? It can be done by various methods, such as mediastinoscopy, open surgery or thoracotomy, EBUS, EUS BFNA, EUS, then EBUS guided nodal cryobiopsy, or EBUS guided nodal forceps biopsy. Right? So we all need to know what is the TNM staging, the T status, the size of the tumor, the position of the tumor. It guides us for the T part of the TNM staging. Then we come to the N part, the nodal part, which we are going to stage by the EBUS. Now, we need to know how the staging of the nodes is done. We always start from the most peripheral lymph node that is present in the absence of PET scan. We go to the N3. If it is positive on rows, we stop the procedure. If it is not, we come to the N2 status, the N2 N1 status. So, what is the N1 status? It is the presence of ipsilateral, peribronchial, and hilar lymph nodes, including the involvement by direct extension. N2 is the metastasis in the ipsilateral, mediastinal, and the subcarinal lymph nodes. It is further divided into N2A and B. Then the N3 is the contralateral, mediastinal, hilar, or the ipsilateral, contralateral, or the supraclavicular presence of the lymph nodes. Then there is the metastasis stage, that is the M part, and we come to the final diagnosis of the TNM staging, and this guides us for the treatment. What is the place of mediastinoscopy in today's practice? I don't think there is much of space left for mediastinoscopy after the advancement of EBUS, EUS BFNA, EBUS cryobiopsy, and everything. Still in cases of false negative patients, after all the modalities have been exhausted and they come out to be negative, still there is presence of the PET uptake. we need to open the patient. We need to do mediastinoscopy or open thoracotomy for staging the lymph nodes or for diagnosing the lung cancer. So this image shows the reason why mediastinoscopy is out of the box right now. We are not using it much because it is much more invasive and the complications also are many. The cost associated with the procedure is also large as compared to EBUS. Then it is done in rigid in the general anesthesia, which also has associated complications of its own. What is linear EBUS? We all know, we are all using linear EBUS. Still, linear EBUS is a real-time ultrasound guided imaging of the airway walls and the mediastinal and the hilar lymph nodes. It also allows us to target the transbronchial lymph nodes for the cytology and the biomarker analysis. Now comes the statement why it is a clinical game changer. This was the topic provided to me. It is a game changer because when compared to mediastinoscopy or an open thoracotomy, it enables us with the minimally invasive, accurate sampling of the mediastinal lymph nodes without disturbing the patient, without disturbing the equanimity of the patient, without disturbing the pocket of the patient. It is cost effective and it has very less complications of its own. And when it is combined with EUS BFNA, it provides us the diagnosis of the mediastinal and the paraesophageal lymph nodes. Accessibility increases, and when they are combined, the sensitivity goes beyond 90%, which is a very big number when you have to diagnose the lymph nodes. So we all know the clinical impact. The EBUS is now the first-line modality for mediastinal staging in cases of lung cancer. Combination increases sensitivity, as told before, decreases need for the more invasive surgical procedures or the patient morbidity and the healthcare costs, and offers the simultaneous diagnosis, staging, and molecular characterization. When compared to mediastinoscopy, it is minimally invasive, the diagnostic yield is high, recovery is same-day discharge, and the complication rate is very, very low. Now, role in personal therapy, it enables us for timely initiation of the personalized treatment protocols. It enables us for sending the sample for molecular biomarker testing. Now, it is well documented by numerous literatures. Of some, I will quote Tremblay et al., European literature, Indian literature, and international literature. They all regard EBUS TBN as a safe, cost-effective technique with a high grade of evidence. And when it is combined, the diagnosis of staging of the mediastinal lymph nodes in lung cancer patients, it goes beyond 90%. And when they are compared to mediastinoscopy and thoracotomy, it wins over it. Anyway, we talked about safety, we talked about cost effectiveness. Now, a procedural overview. We are all doing EBUS every day and day in and day out. Still, just to show my fellow colleagues who are not doing EBUS, they can see it is a very easy procedure, just like a bronchoscopy. We give a local anesthesia. We instill lidocaine on the vocal cords when we reach there, and we insert our scope inside the vocal cords. We pass the vocal cords into the trachea. And now this is how we do the staging. We reach the hilar lymph nodes first. If they are positive, if they are enlarged more than 1 centimeter and they have quite uptake, we sample the lymph nodes, and at that time only the oxygen source is required. That is like conscious sedation. Patient is required to take the oxygen from nasal mask or even a nasal cannula. Then we complete our passes from the lymph nodes. We take the FNAC. We do pass 1, we do pass 2, we do pass 3. Under real-time evaluation, we can see the lymph node, visualize the lymph node, take out the sheath, put the needle inside the lymph node, and take the sample by suction or by the capillary suction method or the vacuum suction method we can use. Vacuum suction is more bloody, but you can get your job done by taking the pass 1, taking pass 2, and taking pass 3, completing your samples, completing your criteria of doing an EBUS, and you come out and you can discharge the patient happy home the same day. Now, presence of rows is very important when you want to stage a lung cancer patient. They only provide you the detail that when to stop the procedure, whether it is N3, whether it is N2, whether it is N1, and also allows the additional needle passes during the procedure if the samples are insufficient, increasing the yield and the diagnostic confidence of the pulmonologist who is doing the procedure and the pathologist who is examining the slides. Now, it comes with a pinch of salt. We are doing EBUS TBN a day in and day out. We know the limitations. It cannot completely exclude mediastinal malignancy, even if they are negative. Then we need to resort to mediastinoscopy or open thoracotomy if it is there, the PET uptake is there. Certain lymph nodes and areas can be difficult to access with current EBUS technology, which are more peripheral than the reachable lymph nodes, that is the station 9. Then ongoing research is also going to incorporate AI in the ultrasound imaging of the EBUS, which is going to improve the accuracy and the efficiency of the scope. So summary, linear EBUS when combined with EBUS EUSB FNA has revolutionized the medicinal staging in lung cancer. It combines the precision, safety and efficiency to become the new standard of care. EBUS facilitates the rapid, accurate staging and molecular profiling of the oncological patient and the oncology management. And its broad adoption reduces more invasive procedures, more complications, and overall healthcare burden on the patient. Thank you.
Good evening, all. First of all, I would like to thank CCI for giving me an opportunity to speak here. So we all heard about the role of linear EBUS in lung cancer staging. So in another 15 minutes time, we're going to see about the role of radial EBUS in peripheral pulmonary nodules. So greetings from Vishakapatnam. So this will be my agenda. So we're going to start with the introduction of radial EBUS, what all the instruments required. So how do we do a radial EBUS and what are the different navigation methods? And role of cryo in radial EBUS for peripheral pulmonary nodule. So we all know the convex EBUS is a bronchoscope. Unlike the radial EBUS, the convex EBUS is a bronchoscope. So that's the radial EBUS. It's just a probe. So what are the differentiations of a radial EBUS probe and a convex EBUS? So the first point is it's a bronchoscope, and unlike the convex EBUS, the radial EBUS has to be passed through a working channel of a bronchoscope. So it's just a probe. So other difference would be the multiple array of transducers are available on a convex EBUS, whereas in a radial EBUS there is a single array transducer which rotates 360 degrees to give image of the airway wall. And this is what the probe looks like. And this probe needs to be passed through the bronchoscope and from in the working channel and identify the nodule. So once you pass the radial EBUS to the nodule, you will get a vision image like this. So that's the center point is the probe, and surrounding all the borders, what you see is a solid nodule. And this is how it looks at an ultrasound image. So coming to the different parts of radial EBUS. So the first one, what you require is an ultrasound processor. So this is an Olympus ultrasound processor which has the connections for radial EBUS and the convex EBUS. The next thing is to rotate 360 degrees, you require this probe driving unit, and that's the radial EBUS. And this radial EBUS has to be passed through the working channel of the bronchoscope. And if you have a guide sheath, so this can be passed through the guide sheath in the working channel of the bronchoscope. Fujinon also has the similar one. So you have the optics and the video processor. You have the ultrasound processor, and that's the probe driving unit, and that's the radial EBUS. So this is how the procedure of doing a radial EBUS with a guide sheath. So once you identify the peripheral pulmonary nodule, so how do you identify? You pass the guide sheath with the radial EBUS into the peripheral pulmonary nodule. So once you identify the image in the radial EBUS, so you leave the guide sheath there. So once you leave the guide sheath there, and you can pass your biopsy forceps or brush to get samples. So that's the radial probe. So you identify on the radial EBUS image the peripheral pulmonary nodule. So once you identify, you leave the guide sheath there. And once you leave the guide sheath there, you can do initially cytology followed by biopsy. So this is the challenging part. We all know the peripheral pulmonary nodules, that's how the cancer starts in the lung. So the majority of the patients, these nodules are so small, so you can't pass your regular bronchoscope into the airway to the peripheral pulmonary nodule. So that's the first point. So one is the size of the bronchoscope. Second thing, and you can't navigate through the airway because you don't know the path how to navigate. So that's the reason. So we need to have some kind of navigation system, otherwise you are lost. So this is the bronchial branch nomenclature. So, so this is the Japanese way how to nomenclature for bronchial branch. So there are six generation we can pass the bronchoscope and the radial EBUS. So we can start with the second generation, that's the RB1. So we call it the segmental bronchus. These are the segmental bronchus, and these are the lobar bronchus. So first generation is the lobar bronchus, next is the segmental bronchus, and followed by subsegmental, subsegmental, all these bronchus. We can guide our radial EBUS and follow the path till the fifth or sixth generation. And this is how it is labeled. So 1, A, I, alpha, and X. So before we start doing radial EBUS, we should always well versed with the nomenclature of bronchial branch tracing. These are all on the right side. These are all on the left side. We have 10 segments on both the left and right. But some segments are absent on the left, and some segments are combined, like LB1 plus 2, whereas RB1 and RB2 are separate, and LB7 is absent in the left. So this is the normal things which we have to well verse before we perform a radial EBUS for peripheral pulmonary nodule. So as I've told you, we generally use this bronchus, that's the therapeutic bronchus what we have. So this has a working channel of 2.8 mm. But this is not so good if you want to perform the radial EBUS. You need to have multiple scopes, and these are the scopes available. These are the scopes available in the market. So what we are interested in these two scopes. So forget about which company manufactures, but what we are interested in these two scopes. The one is an outer diameter of 4 mm, another is an outer diameter of 2 mm. Another one, outer diameter of 3 mm and 1.7. But if you have one scope, at least 4 mm, 2 mm, your job is done. And this is an extra advantage. So coming to the navigation bronchoscopy, the first system what we have currently in India, and many centers have this, is called the lung point. So where you can insert the DICOM software inside and DICOM CD inside the software. So once you identify the nodule, so it will give you the path, and it will also give you the directions when you are performing a bronchoscope. So it will give you the directions which segment has to be taken and how far is the mass from the segment. So this is of great use, especially if you have the system 100% you can use it, but it comes at a cost. Currently, the lung point stands around 50 lakhs to 1 crore rupees. So the next segment is the BTP. So this includes navigation and also includes the tunneling device. So what is tunneling? Because we're going to come about that CT bronchus sign in the next slides. But if you have an airway directly leading inside the peripheral pulmonary nodule, it is very easy to pass your instrument. But if you don't have an airway leading inside your PPL, so you can use this system where you can puncture the airway proximally and do a tunnel and go to the nodule safely with this system. So another system is an electromagnetic navigation, what we don't have in India as of now. So basically the system uses a magnetic board where the probe can be detected on the board. So this can be incorporated in the software, and you can identify in not in real time, but you can identify in most of the cases. So coming to the cone beam CT and robotic bronchoscopy, we'll just come to the next slide, and I'll let you know what is cone beam CT and augmented fluoroscopy. So when you have a sub-centimeter nodules, and they are challenging nodules, so this is a small sub-centimeter, probably around 6 mm or 8 mm nodule near the mediastinum. That's the arch of the aorta, that's the pulmonary artery, and this is the ascending aorta. That's probably at the arch of aorta. So to target this nodule, it is not so easy. So what the system does is it incorporates a CT scan while performing a bronchoscope. So the CT scan will give an image in all the different planes, the axial plane, sagittal plane, coronal plane. So you can see your tool, that's the biopsy forceps, inside the lesion. And this you can map it before. With the help of augmented fluoroscopy, you can do the biopsy in real time. So you don't have to do CT scan every time. Once you identify the nodule once you identify the nodule in the CT scan, you can do an augmented fluoroscopy. But that comes at a cost. What we'll do is to use an DICOM software. So first thing is to identify the target lesions. How do? You do a CT scan, you identify the nodule. The second thing is the mapping. So here you use the DICOM viewer or the software, the Radiant software. So once you use the software, you will get to know the path of this nodule. So this is what I do in most of the cases. This is the left upper lobe lesion. This is the left lower lobe LB3 lesion. And I usually identify the nodule with a map. So this map will help me to guide my bronchoscope into the respective segment. So again, navigation, you have this map, you keep this map inside of your bronchoscope image, and you identify the segments and you go accordingly. So you can use a guide sheet, or without the guide sheet also you can be done. So radial EBUS confirmation, yes, once you confirm the nodule in the radial EBUS, you need to remove the radial EBUS. Again, that's another drawback of radial EBUS. It's not in real time. So there the CM helps a lot. Identify the nodule on the CM and you can do biopsy in real time. So biopsy can be done with needle, biopsy forceps, and cryo. So we're just going to come with a 28 mm solitary pulmonary nodule in LB4. Elderly lady, CT scans showing nodule looks to be malignant. So that's in the lingula. So once you have identified the nodule in the lingula, you need to identify the target bronchus. That's one I have told you. You need to identify the bronchus leading into the lesion. So that's the lingular bronchus. It is going directly inside the lesion. All 4 and 5 both are going inside the lesion. So what I've done, I have flipped the CT scan. So once you flip the CT scan, that's the left main bronchus. That's the left upper lobe. So that's the left lingula. That's where directly leading inside. So this is in line with your bronchoscope. So when you see inside the bronchoscope, starting from trachea, left carina, right main bronchus, left main bronchus, that's how you look at in the CT scan the same way. So now you identify the path and you make a map. So once you make a map, it will be very easy when you're performing a bronchoscope to identify. So use the same map, that's the left upper lobe and that's the lingua. This is the easiest of all. It is directly inside the second generation or the third generation. So you can identify the mass in the radial EBUS and you leave a guide sheet and do multiple biopsies looking at the CR. So this is how a normal lung looks. If you just pass a radial EBUS into the lung, this is how a normal lung looks. But whereas if you have a peripheral pulmonary nodule, and once you pass the radial EBUS, this is how a solid lesion looks. So there are relations between the peripheral pulmonary nodule and the probe. And this is what we are more interested in. If you have a peripheral pulmonary nodule and your probe is directly at the center of the peripheral pulmonary nodule, this is what the image you can get it. This is called as within image. So the probe is inside the nodule. In eccentric image or an adjacent image, the probe is next to the nodule. But if the probe is inside the nodule and at the periphery, so this is called an eccentric image. So you can see the probe is inside the nodule, but it is at the periphery. So it's called an eccentric. In adjacent, it is probably not inside the nodule, but it is next to the nodule such that you can have an image. So that's where it is. So you have the probe and you have the nodule. So this is probably an adjacent image. Whereas an invisible image where the probe and nodule are far away and there is a lung in between the probe and the nodule, you will not have any image of the nodule. This is what is called as invisible. Why this is very important? Because the chance of you getting a diagnostic yield is very, very high if it is within image compared to an invisible. Invisible, the diagnostic yield is hardly anything. In eccentric and adjacent, it is better than invisible, but it is less than the within image. So what best we can do to convert this eccentric and adjacent to increase the diagnostic yield, will come to that in the next slide. So this is what we will use in a Radial EBUS. So this is the cryo system. We have different disposable probes. We have 2.4, 1.7 and 1.1. So this is what we are interested in on 1.1 probe, because this can be passed inside the working channel. That's a 2 mm working channel or 1.7 working channel. So what can be done with the cryo probe? So these are the feasibility studies in 2016, whether you can pass a cryo probe inside the thin cryoprobe inside the peripheral pulmonary nodule. So these are the initial reports from Dr. Kedar Hebar, a good friend, in 2017. What they have done, they have taken Radial EBUS cases and they compared with a forceps biopsy, cryo versus forceps, because bronchoscopically invisible lesions. They compared forceps versus cryo biopsy. So what they have seen, they have good number of concentric and adjacent cases and less number of invisible cases. But if you look at the yield, so there is no big difference between the concentric and the adjacent, and this is surprising. But usually in the concentric image, the yield increases. So they also didn't find any difference between the cryobiopsy and the forceps biopsy. So what are the disadvantages in this one is they used a thick bronchoscope and they have not used a thin cryoprobe. So that's the drawbacks of this study. So in the next study, this is by good friend Dr. Zhe Ho. In 2019, what he has compared was the role of cryobiopsy in eccentric or adjacent cases. What we have seen, if you do a forceps biopsy in eccentric or adjacent, it is around 50% chance to get an yield. But if you do a cryo in these cases, the yield increases to 75%. So definitely shows a better yield of cryo in cases of eccentric or adjacent images, whereas in concentric there is no big difference. So coming to the next good paper in Lung India, our good friend Dr. Nagarjun Maturu, this is published recently in July 2025. 50 cases of cone beam CT where they had difficulty in doing a Radial EBUS initially. So they performed a cone beam CT in this case. So they made 3 types of lesions. So one, if in the cone beam guidance, so if they have the probe within inside the lesion in more than 2 planes, they call type 1, and it is touching the head, they call it as type 2, and it is outside or it is an invisible, they call it as type 3. So they had CT bronchosign in 86% of the cases. So the bronchosign is not there in 14% of the cases. So this is what the difference is. So if you have bronchosign positivity, the yield is 93%. Whereas if you don't have a bronchosign, the yield is 57%. So that means you have a nodule and you don't have a bronchosign. So if you don't have a bronchosign, probably you're outside the lesion, or sometimes you can convert this patient who doesn't have a bronchosign through a within image sometimes. So look at the diagnostic yield compared to the size of the lesion. So because you're using a cone beam CT, you can do a sub-centimeter nodules, so less than 10 mm. So less than 10 mm nodules, so that's the diagnostic yield, around 50%. So half of the cases they could able to get the diagnosis, because all these sub-centimeter nodules, majority are outside the lesion, or you don't have a CT bronchosign. So that's the drawback of this sub-centimeter nodules. In less than 50% of the times you can get diagnosis with a cone beam CT. Whereas if you look at the nodules more than 20 mm, the diagnostic yield is 100%. So that's the greatest differentiation. So how to start a Radial EBUS? I feel that you should always select cases, and the best cases would be lesions more than 20 mm and with a CT bronchosign. So instruments, Again, the two scopes, what I've told you, 4 mm, 2 mm, or a 3 mm, 1.7. It's better to use a guide sheath. Even without a guide sheath, it can be performed. Biopsy force is preferably 1.8, but it is difficult to do with the 1.8 with the guide sheath. So you only do with 1.5 mm biopsy forceps. TBN needle is very good when you want to convert an eccentric image to a within image. And there is a dedicated flex needle called a periview flex needle, and wonderful needle. You can do cytology in cases where you can't do a biopsy. And this is the game changer, I feel, the 1.1 cryoprobe for all my cases now. As of now, if you are doing the radial EBUS, it's always a cryo biopsy rather than a forceps biopsy. Fluoro is the greatest advantage because, again, I've told you, radial EBUS is not real time. You need to have some guidance when you're doing a biopsy. Fluoro comes at great help. So if you have this, if you have a virtual bronchoscopic navigation software or a CBCT, definitely your EBUS, radial EBUS yield increases. So don't select these cases, small nodules, sub-centimeter nodules, ground glass opacities, a nodule which don't have a bronchus sign. You need to select these cases where you have a good bronchus sign, large nodules, and you will definitely have better yield. To conclude, radial EBUS is a safe and effective procedure for peripheral pulmonary nodule with minimal complication rate. So it started choose the right case. I feel the size of the nodule and the CT bronchus sign plays an important role. So get a 1 mm DICOM CT images, use a DICOM reader, do a bronchial branch manual mapping. So you will have a better idea from which segment or which subsegment to be taken, and try to get a within image as much as possible because that's where the yield is the maximum. And for eccentric and adjacent lesion, cryo is definitely advantage. Thank you for your patience.
Myself, Dr. Rakesh Godara. I am a senior consultant at CK Bala Hospital, Jaipur, Rajasthan. So in the last talk that we'll discuss about the malignant central airway obstruction and consideration about rigid bronchoscopy and stenting. So we know about the malignant central airway obstruction. It is a cancerous growth that causes the endobronchial obstruction. It could be a central airway or distal airway, and could be intrinsic or extrinsic or mixed growth. We can see that it can be caused by direct invasion of the tumor or by the extrinsic compression or kind of a metastatic of the surrounding organ like thyroid, esophageal, or the breast carcinoma, or it could be a kind of a remote metastasis like renal cell carcinoma. The most common cause is still the lung cancer, the near about account for 70% of the cases, and the 10 to 15% of lung cancer cases present as an initial presentation of mechanical, the malignant central airway obstructions. According to two registry, that Epigative and the Acquire registry, squamous cell carcinoma is one of the most common. Other than the esophageal or renal cell carcinoma are the rest of them. What is the aims and objective of treatment? The therapeutic bronchoscopy leads to the palliative interventions. Primarily aim is that recanalizing the airway and improve the quality of life, and also work as a bridge to give the time to the patient for further antineoplastic treatments and improve the quality of life and survival. But all these treatment, they largely depend upon the various factors, and because it's a heterogeneous disease, so the patient's preferences and expectations and your initial patient status, in what condition that he has reached to you, and the tumor factor, what the pathology and tumor vascularity, the clinician expertise and local available resources. We categorize the malignant central airway obstructions and to decide about assess the severity and therapeutic success and prognostications. So that's why the one classification is not enough, but the one classification that commonly used is the location by the extrinsic, intrinsic, or the mixed. Because looking at this one, that we decide about that whether we need to go for a alone debulking therapy or plus minus your stenting. And also that your symptoms and severity depend upon where the tumor lies, whether it's a proximal or the distal airway, and what is the vascularity of the tumor. And also we look for the pulmonary artery obstructions, because sometimes opening of airway and you're restoring the airway, but with the pulmonary artery obstructions can lead to the VQ mismatch and the desaturation. And presence and absence of the fistula also affect the survival. Symptoms are highly variable and non-specific. They depend upon the degree of the stenosis, at what location of the tumor is there, and also the baseline patient's cardiopulmonary reserve. Immediate the treatment modalities are the bronchoscopic modality, where the combined rigid and the flexible bronchoscopies are used along with other ablative therapy that could be hot and cold, plus minus that your stent can be used looking at the for mixed and extensive compression of the patients. So approach of the treatment depend upon the tumor's pathology and malignancy type. And we know about the like small cell carcinoma or lymphoma, they respond very well to the chemotherapy. So we generally avoid to putting a stents, or if we put a stent, then it's a tendency or intent of that we can remove it later. And solely endobronchial tumor, they do not require any kind of stenting. A patients with the adenoid cystic carcinoma or carcinoid, they can be sent after restoring the airway or the removing of obstructions. They can be sent for definitive therapy, including surgery. Indications of stenting is there: symptomatic relief to maintain the airway patencies, or bridge to the definitive therapy and palliative care. This is one the position paper and clinical practice guideline for the stenting in airway, both for benign and malignant. That was last year in May, and it has been shown that they have asked for the question for the regarding the malignant central airway obstructions and what are their impact on the quality of life, and the what preference to given to the treatment. And they have shown here that there is no superiority of metallic versus silicone stent, that largely depend upon that your local availability and expertise, and also the patients and the tumor factors and airway factors are there. But here this guideline strongly they suggest that the patient should be given the treatment in terms of that to improve the quality of life and performance status. And also the patient who are on ventilator with due to airway obstructions, the priority should be given to restoring the airway patency, so that patient can be weaned off from the ventilator. They have again also put a concern on the two important things, that bronchial hygiene and the surveillance bronchoscopy. The bronchial hygiene, because and everybody is suggesting that that these patients should be given for a saline nebulizations. It could be a normal saline or 3% and 7%, or sometime mucolytic can be used in case of the thick mucus cast. And surveillance bronchoscopy, though there is no fixed guideline, but then it is recommended that in initially 4 to 6 weeks, you can go for a surveillance bronchoscopy. Preferably when the patient do not develop the symptom, before that you should go for a surveillance bronchoscopy to identify early granulation tissues or stent migration. There are two kind of the stents are there, metallic and silicone. Both have their advantage and disadvantage. That also depend upon that what kind of the tumor you are treating and what is your priorities and what is the airway status. And they have their advantage and disadvantage. Bare metallic stent, less chance of migrations, but tumor ingrowth is an issue. Covered stent, they are rapidly deployable and good kind of a tensile, the radial expansion, and but slightly more chances of migration in comparison to the bare one, but they impair with the mucus clearance, but easy to deploy. And silicone stent, the advantage of the silicone stent is there because they can be easily removed because they have an inert material, so they're less kind of the interactions with the human airway. They can be customized according to the length of the your steno segment, and less impedance with the mucus clearance is there. Stent complications, it could be a mucus plugging and the granulation tissues, stent migration, infection, airway erosion, or excessive cough. For the mucus plugging, then we know chest physiotherapy and bronchial hygiene is required. For granulation tissues, we need to keep in mind that oversizing increase the granulation tissues, and that are more with the metallic stents. And the stent migration, undersizing obviously lead to the stent migrations, but it can be kind of repositions by that looking at the surveillance bronchoscopy, early identification, proper sizing, or sometime for the proximal airway, you can put a hitch stitch. Infections very well can be treated with the antibiotics by the sputum culture and all, rarely require that stent removal. Airway erosions, though rare, but can happen with the patient with long-standing the metallic stents. Sometimes that stent can fracture, they lead to the airway perforations and damage. Excessive cough due to kind of the undersizing of the stent, that could cause the irritation to the airway and can be managed with the cough suppressant, but sometime it might require the removal of the stent, but though rarely. So we'll discuss here with the one case base that understand that what are the stents and how we require. This is the first case where we can see this is a case of the purely extrinsic compression of the central airway mid-trachea due to esophageal growth. And here we have under fluoro over the guide wire, we open the stent, and by carefully selecting the length of this segment and then size of your metallic stent. This was a case where the large tracheoesophageal fistula, because of the esophageal stent that came into the your trachea. You can see clearly here that stent, this is a esophageal stent, and it popped up into the trachea. So that's what this is a tracheal lumen. So first we have to restore the lumen patency. So that's why we compress or press the stent with the rigid barrel, and after that we examine the distal airway. Once the distal airway was examined and secretion was removed, this is a carina. You can see the large esophageal fistula going through the mid trachea to the lower trachea, carina, and up to the left mid bronchus. And you can see the distal part obstructed with the mucous secretions. So after clearing the secretions and over the guide wire under fluoro, Y stent was placed. So the future considerations are there, because we know that no stent is perfect. So that's why we to decrease the granulation formations, drug-eluting stents are under the research. 3D print stents are there also, because then airway have a heterogeneous and their structures, and especially with the left main bronchus, that it is in the curved structures. So the straight stent do not fit, and high chance of migration in the left main bronchus. So that's why 3D printed stent is the one of the best choice for that. Still, that pricing is very high, and they are still in the investigational part and not in too much of used. Biodegradable stent is definitely, it is one of the required, because where you are thinking of removal of the stent, so that the stent should do their work for 8 to 12 weeks, and after that it degrades by itself. So that's maintain the lumen patencies. But again, that costly and not commonly available. Through the scope stent can be inserted, where that kind of their ease of the insertion under vision, so that accurate assessment and also exact positioning of the stent. But again, that they are the thin, so the tumor ingrowth and mucus plugging is the issue. So to conclude, the malignant central airway obstructions, its symptoms include potentially fatal respiratory failure, and the technical challenge arises from the severe obstructions, patient with the renal failure, lung cancer, and the high ASA score, left main stem disease, and large tracheoesophageal fistula. They all impact the survival and quality of life. The bronchoscopic options include the mechanical debulking, ablative therapy, and stent placement. In selected patients, these interventions improve the quality of life and act as a bridge to the definitive cancer therapy. Ideally, the no stent placement is the best. That's why then we are looking for either the silicone stent placement into the malignant airway or the biodegradable stent. With the newer therapy, the longer cancer survival, the removable stent should be considered for carefully chosen cases. Thank you.
Thank you, Aditya, Bala, and Rakesh for your lovely talks. We now move on to the panel where we are also joined by Dr. Govind Desai and Dr. Jaykumar Mehta. So, starting with Govind, what are the current indications for using linear EBUS in the staging of lung cancer? If you can elaborate. I think you are on mute, Govind.
Yeah. So good evening, everyone. So can you hear me?
Yes.
Yeah. So as we start with the basics of the interventional pulmonology, that is the endobronchial ultrasound, particularly the linear EBUS, there are few indications which are very preempt and particular. Number one, most of the time when we plan for an EBUS, we either get a CT chest, that is a contrast enhanced CT chest, or the patient is referred to us by an oncologist with a PET scan. So any PET avid lymph node or any CECT which has an enhancing lymph node and is more than 1 centimeter, that's an absolute indication to go for a EBUS guided biopsy or a EBUS guided FNAC, because this is going to be helpful for us in the pathological diagnosis and treating the cases. Number two is a radiologically normal mediastinum. So a lot of times we have a disease in the lungs, we have the disease in the parenchyma of the lungs, and the mediastinal lymph nodes are almost normal. So these are particular cases where we stage them as N0 or an N1 case. In such cases also, there are something called as an occult nodal involvement of N2 or N3. And the data suggests that almost 7 to 10% of such cases, we can actually diagnose them and may avoid a surgical resection. So patients who are affordable, and most of the time, if an oncologist has referred to us, we should always advise for an EBUS in N0, N1 cases, because we might diagnose such cases with N2 and N3 as well. That is around 10% of the cases. In cases where we have an N2, N3, it's a textbook definition. We have to go for an EBUS because most of the time the sensitivities are around 85 to 95% in such cases, and it is going to be of a great tool in diagnosing. Number 4, which is very important and almost every day followed by us, is a molecular marker diagnosis. Most of the time we need an IHC, we need an NGS in cases where it can be done. So in such cases, a biopsy, particularly from the lymph nodes, can be of a great help. Other than this, I think one common indication which we all of us follow and which is not officially being given in the guidelines is a central lesions, but which are eccentric. If we do a bronchoscopy and we find that these lesions are not there in the bronchus and these are eccentric lesions and they are central airway lesions, so in such cases also EBUS can act as a great tool in taking a biopsy most of the times.
True, very well outlined, Govind. And I think in our setup, it's very important that you said that you have a lot of oncologists referring patients to you for staging. In places, it's the reverse. In fact, you have to tell them that please refer everything that lights up is not necessary cancer, right? Especially in our country. So it is important. So many times when they send you for staging, you actually pick up concomitant tuberculous disease. So it's important that we do these procedures because you may change the management of these patients. So that's also important, especially in our setup where infectious diseases are endemic. So, Bala, Aditya has told us extensively about the procedure and Govind has told us the indications. Is there anything for the younger people out there listening to this, any difference in the needle size which would change the way you take a biopsy or change your yield? What would you recommend?
So we have a couple of sizes as of now. So we have the 21, 25, 22, 19. So these are the sizes of the needles as of now available, the 4 sizes. So definitely there is no big difference between the 21 and 22. It doesn't change, the yield doesn't change. But 25 needle has the greatest advantage, and especially in lesions, 10L lesions or 4L lesions. Definitely 25 needle has an advantage because it can reach the lesion much better than the 21 or the 22 needle. So that's the difference what I have seen in my practice. Coming to the next needle, that's the histology needle, that's so-called histology needle. So there is a data showing that it is better in cases of lymphoma and in some cases where the 21 and the 22 have failed. But still, practically to speak, I feel there is no big difference between the 22 and the 19 gauge because you get more blood. So that's what I felt. Regarding the other more recently launched needles, that's the newer tip needles, that's the Francine tip needle, that's acquired needle by Boston. So they have definitely shown increased yield in these cases, but again, it comes to the point that it comes at a cost. So it's almost like 1.5 times more or 2 times more than the cost of the normal 21 or the 22 gauge needle. So should you do on all the cases upfront in this expensive needle, or you have to reserve this needle when something is failed is the question mark. But definitely the Francine tip needle has shown to give better yield compared to the 21 and the 22 gauge needle. So I think safely we can stick on to the older needles, that's the 22 gauge needles. They are pretty good. But in today's practice, if you ask me what is the next step to go if you don't get a yield in a 21 or a 22, I feel you should go to a better yield giving procedure. I feel it is a cryo. So mediastinal cryobiopsy has proven to give best yields compared to whether it is a Francine tip needle or a forceps biopsy. So cryo probably holds better, but that's not the point of discussion now. So compared to the needles, I feel we should still stick to the 21 and 22 gauge needles.
Yeah, absolutely. I think the 25, the 19 gauge, what we have all seen in practice is that malignant lymph nodes can sometimes just bleed, without any warning. So that is also there, especially with 19 gauge, we have seen that. So very well put. Uh, so coming back to Govind, how reliable is EBUS in evaluating N1 versus N2 versus N3 nodal stations in
Right.
terms of
So I think,
efficacy?
yeah. So as we all know that most of the time when we do an EBUS, it's most of the time targeting the N2 and the N3 diseases. The data do suggest that almost there's a sensitivity of 85 to 95% of sensitivity with the EBUS for N2 and N3 nodes. As we all know, most of the time we target the nodes if they are particularly in the paratracheal, the upper and the lower paratracheal, the subcarinal and the hilar. But often do we end up also doing the station 11, that is the interlobar, particularly in the right side as well. So if you look into the data, it's almost 85% of sensitivity with N2, N3 disease and almost a specificity of 100%. But when we come to the N1 diseases, now these are the diseases where it's little difficult to pick up. And most of the time in N1, we only try to focus on the interlobar group of lymph nodes, that is the 11R, superior and inferior group of lymph nodes. Here, the yield is quite good, but overall, if we take the N1, it's almost 60 to 70% sensitivity. So the sensitivity does come down. So here, when we are not that confident, I think if we have an N1 disease, we don't have the N2, N3, it's always better to even go for an option of VATS if there is a surgical resection being planned in the procedure. Again, another important thing is N3 disease. Most of the time, clinical evaluation is very important because it's such a cases that we might find that there is a supraclavicular lymph node which might be missed up on a clinical examination, and a simple FNEC can diagnose it. So I think before going for an EBUS, it's always better to go for a clinical evaluation, get back to our basics. If we have an opposite contralateral supraclavicular lymph node palpable, try to get a simple FNAC. Maybe we might put up this diagnosis and avoid EBUS in such cases as well. So if I have to put it up, it's more of an N2 disease, N3 disease without a contralateral supraclavicular lymph node. And in N1 diseases, if it's not an intralobar group of lymph nodes which are being appreciated on an EBUS, it's better to go for a VATS in such cases. So EBUS has a good sensitivity for N2, N3 diseases.
Sorry, I was on mute. Aditya, your insights on this? Anything to add?
Ma'am, same as Dr. Govind said, the sensitivity of N2 and N3 disease is around 95% and goes to 100%. Even the guidelines, ATS, ERS, they also document the same thing. But when we come to the N1 diseases, the sensitivity comes down to around 50 to 70%. Even in a study in 2015 by Dr. Felix J. Hurt, they had documented if the lymph node is less than 1 centimeter, you may resort to, he said that VATS, you may also resort to EBUS and forceps biopsy of the transnodal forceps biopsy to get the yield more. But yeah, correct. N2, N3 is the most easily targeted by the EBUS, the linear EBUS.
Sure. So moving on, Rakesh, Bala mentioned NGS. So what is your opinion? Is NGS the game changer in evaluating the yield, and do you recommend it routinely? Because it is expensive. It may not be possible in every patient.
So, right, ma'am. So, first of all, it's an expensive test. So, it depends upon the tumor that are the cytology, because what kind of the tumor is there. Because for the non-small cell adeno, definitely NGS is upfront nowadays recommended, but if the cost is not the issue. But for the small cell and squamous, that the data is not say strong. So definitely, and because there are the 12 gene panel is there, that is the NGS, and where the EGFR, L cross, BRAF, and RET, these are the some of the genes, and it can be done both with the tissue and the liquid. Though the liquid biopsy have the less yield, but it can be done. But definitely it is a recommended test nowadays. And for the non-small cell adeno, where then our treatment strategies can be modified and limited disease, definitely we should go for that.
Yes. So I think in low tumor burden tissue is what, is ideal. Now, I know none of us have spoken about rows in enhancing your diagnostic yield. I mean, what does the panel have to say about it? Whether it's linear, whether it's radial EBUS. Aditya, Rakesh, you can take the linear EBUS question.
Yeah,
Do you all do it routinely?
Yeah, so the rows we don't do, because then, but then the rows is only one thing that it can decrease the time, because you do not need to, because if you get the tissue, because especially the malignant patient where yield is very high, and so you can kind of stop your procedure before that, rather than you keep on doing the taking the samples, and adequacy of the sample, and second, that you can expedite the process. Second thing, then rows is important where you are nowadays, as Bala was talking about the cryo biopsies, because every patient you do not need to end up into the cryo, especially for the sarcoid and lymphoma. If your rose is giving the adequate tissue, then you do not require it, because otherwise then it is very difficult for us for a patient where then yield is very low, like sarcoid and lymphoma, and you've taken a tissue, and then so sometime then you see, then you've taken a cryo also, and later on you see then you got a tissue in FNSC also. So this is how the rose plays into it. Is not always required, but then definitely it is how it has been placed in the algorithm.
Yes. Bala, any thoughts? Are you using it routinely for your PPLs?
No,
You
definitely.
would like to. I know you would like to, but
I will echo what Rakesh said, the same thing, because yes, I don't have the luxury of rows in my center and setup. The best we can do is to get maximum samples as much as possible from the node, and we all do the same technique, the fanning technique, do multiple sites as much as possible, minimum 4 passes per lymph node station. So that's what everybody follows, but whoever doesn't have rows, so there is no option at all. So the only thing, if you have the rose, the luxury, what Rakesh said, definitely your sensitivity will increase, because once you have a negative rose after 2 3 passes, definitely you're going to change your technique. There's no doubt. So definitely you will have a better yield compared to a person who's not doing a rose. So in my center, yes, I don't have the luxury of doing a rose, so we end up taking more samples than coming out early.
yes. I think now with the cryoprobe also being disposable in some centers where you aren't able to reuse the cryoprobe, maybe rose may be a cheaper option than going for cryo directly. So that could be something for consideration for some people who have the option of using rose. So coming back to you, Govind, how often do we really land up doing lymph node staging in our Indian setup? Because what percentage of patients present with resectable lung cancer in India? I know we have a different perspective and different percentage on it compared to the West.
This is quite a difficult question for a young pulmonologist like me. But frankly, ma'am, I'm associated with an onco-based setup where I work. But still, the number of cases, what I get, particularly where the onco surgeon or the surgeon wants to decide whether they want to operate it and they want to upstage or downstage it on an EBUS, is very minimal, or maybe a fraction of cases, saving maybe around 5% or 10% of the cases if I look at it. So this is something, a big challenge. Probably the financial feasibility is a major concern, for which the referrals for getting a EBUS before a surgery is an issue. I basically practice in a tier 2 city. I would also like to know what is the practice in the tier 1 cities in such cases.
Yeah. So anybody else? Bala, I heard you nodding your head, or I think he's busy on a call. So Rakesh, Aditya, Jaykumar, all of your thoughts on this before I tell you what my experience is.
So, ma'am, I think that the frankly speaking, that we are not getting that too many patients until unless then you are working in a kind of a directly that oncology setup. So you don't see, or otherwise then you have a kind of a decent referral system. Then definitely, so if I'll tell honestly, then not too many patients are there. They are end up into the kind of first A or 2A, 2B kind of thing.
True. Also, I think we are not practicing lung cancer screening on a wide scale, which is happening in the Western population. So I think that is why they are picking up lung cancer much earlier. Their level of overall level of awareness of the patients and the general population is much higher compared to what happens in the Indian setup. It's that, at least is that what I see, is that that's why our patients present to us much later. And what you rightly said is probably 5 to like even 10% would be a higher estimate. I think it's on an average 5% of patients which come to us with resectable lung cancer, even in large volume centers. So I think there are newer AI based models also coming in health checkups. I know there are some of them, I forget the name, but a lot of them are popular, which pick up small lesions, of course. So maybe this might change in the future. Our diagnostic modalities also will change. So moving on, Jaykumar, coming to you.
Yes,
What is CT2 body divergence and why is it important to factor this in while planning to sample the peripheral pulmonary lesions?
First and foremost, I would like to thank CCI family and the esteemed panelists. I'm getting so much of knowledge from all of them. Coming back to your question, ma'am, about city to body divergence. So it basically came when I was planning my nodal clinic program at our center. And city to body divergence is it's not that much popular concept, but it makes a really impactful understanding when it comes for a real time biopsy. So what CT to body divergence refers is that there is some discrepancy between the location which we are seeing on the CT scan, which is done pre-procedure, and the location of the lesion, which is there when we are doing or operating the procedure. So CT to body divergence can be up to 3 to 4 centimeters. Majorly, it is related to the respiratory movement of a patient, particularly the lesion which is situated in the lower part of the lungs, where there is constant diaphragm movement. So suppose if you are planning to biopsy around 2 centimeter lesion or less than that, then that particularly if it's near diaphragm or in the lower lobes, then it becomes very difficult even with the help of C-arm, whether particularly in female patients, whether you will be able to get that nodule or not in a real-time vision. So CT to body divergence is a invisible enemy to get a good yield. Even with when I got my radial probe EBUS, it's basically very easy for me whenever I trained myself familiarizing with this many images, any consolidation, any cavity, any solid lesion, subsolid lesion. We just, before we do any procedure, we just have to put our scope, our probe there, and just see the interface, the radius, the ultrasound images, and then we get the idea, we get familiarity with that, and then we don't have to do any biopsy. We just come out and we do the procedures. That's how we learn the interpretation of the radial probe images. What is continuous margin, discontinuous margin, white spots, black spots. But the real thing is that real threat is that when I was trying to get into the CT guided, like the CT has told, right lower lobe anter-segment lesion, and when I'm going into the sister branches of the bronchus and I'm not able to see this lesion, even if I have done the bronchial branch dressing and all, because of this CT to body divergence. Well, the CT is done in heads-up position in full inspiration, while bronchoscopy usually we are doing in hands-down position with a tidal breathing. So with each breathing, this location of the nodule, which is very small itself, it changes and it is an invisible enemy indeed for getting a good yield. So that's why the CT to body divergence concept is very important to understand. And to counter, we need to adapt some strategies. I think we'll be discussing it later in our discussion.
Yes. So as you rightly said, it's more important in smaller lesions. Also, when you're doing bronchoscopy, whether you're giving GA or whether you're using conscious sedation, so how much atelectasis happens, all those things factor in when you are trying to reach the lesion, especially if it's more peripheral and more small. So, Aditya, how is the location of peripheral pulmonary lesion that decides your radial EBUS yield? In Bala had shown a couple of CTs in his presentation. One of them had a very peripheral lesion. One of them had a reasonably central. One of them had a large CT bronchus lesion. So how does it change your yield?
So, ma'am, as Dr. Bala had showed that diagram, the more the central, if it is available, the bronchus cutoff sign is positive, and if your bronchoscope lands up in middle of the lesion, the yield is more. So, more if the radial EBUS shows significantly lower diagnostic, the radial EBUS shows significantly lower diagnostic yield when they are placed more in the right upper lobe or peripherally, or the lesions are smaller than 2 centimeter. Even a randomized control trial was done in India, and in right upper lobe lesions, the positivity was around 20% as compared to the CT guided biopsy. Even a meta-analysis also supports that the bronchosine cutoff positive on CT yields was 76% as compared when they were negative to around 52%. So the lesions located more medially, more adjacent to the major vessels, and more accessible by bronchoscope, they are going to be more positive as compared to the lesions which are more peripheral or the pleural based lesions which favor the CT guided biopsy in those kind of cases.
You choose the wrong patient, you will be disheartened, especially early on in your career. And secondly, it would be a disservice to the patient. So I think it's important, and that's why these webinars are important, to understand which patient to select. So, Jaykumar, again to you. I know Bala has already touched upon the manual bronchoscopic navigation drawing and the bronchial branch tracing technique. How I mean, I know all of us don't have the luxury of having virtual navigation because it is expensive. So, I mean, do you use it routinely? How easy it is? The learning curve is a bit tough, I know, and you have to be really good with your CT, probably even better than your radiologist because you have to sit and look at it again and again. But I mean, do you do it routinely in your practice? I know Bala showed that he does it routinely for PPL.
Ma'am, it's basically the inspiration is Bala sir. The way he draws the diagrams, it's unmatchable. It's the quality of Dr. Ko, which I can see him, which I can see and understand. To be very honest, I was never replicate those drawings, the maps. I had so much difficulties. And actually, that's the beauty of this bronchial branch tracing, also known as hand-drawn bronchial navigation, that we need to understand actually where the airways. We don't have to give so much importance to the nomenclature, but we just need to know where the map leads us. And in a way, like me, some of my colleagues, we have all developed our all indigenous system of mapping. Like we will not be that accurate of the of the figures, but actually we ultimately lead to we know that we'll be navigating to that part of the lungs. And I think that's why the bronchial branch tracing makes a lot of importance. But for that, we need to have very good quality of inspiratory CT scans, particularly as sir has mentioned, 1 mm thickness. Sometimes what happens, we got PET scan images. And PET scan images in lung windows, they have 1.25 or more mm thickness. And that's where it becomes really tricky to get to the sister branch. Now, important thing is that radiologists are not much trained in doing bronchial branch tracing. In a recent case, I had a discussion with my radiologist. He told right lower lobe, entry basal segment, that's the bronch. Then I told what are the subdivisions, and then we were lost. So that is actually real thing where sometimes they were only writing right lower lobe. Then now we are pushing them to write with segment. Now they are writing a segment. Now we are able to, we are forcing them to tell which sub segment or which bronchus is leading to that. I think it will require themselves. So that's why the role of this type of virtual navigation bronchoscopy comes. One of the very good tool is Synapse 3D. It's by Fuji. But again, it's based on, as sir told, on the DICOM images of pre-operative or pre-procedure, which we have got. So that doesn't give us real-time image or real-time guidance. It just gives us the map. But as per my information, it doesn't give us real-time map. So for that, what we have is body vision. That is basically C-arm based therapy, where we can load pre-op map, plus we have real-time C-arm based guidance with the augmented fluoroscopy. And I think this is very important because we can make last minute changes to counter city to body divergence. And ultimately, there is cone beam CT, the lesions which are very small, very peripheral, very much susceptible to this city to body divergence, and where we absolutely don't, the patient is high profile, or where we cannot afford to miss the diagnosis. We have to ensure two-limb lesion confirmation with 3D multiplanar confirmation. I think cone beam CT guided biopsy is one thing which ensures that we lead there and get a good diagnosis. So in short, ma'am, bronchial branch tracing is now becoming very fundamental to our pulmonology training. But if we have some guidance from Synapse 3D tool, then also one more important factor why bronchial branch tracing or manual tracing is important is sometimes this mapping, the virtual mapping, will misguide us on fifth or sixth generation, where manual bronchial branch tracing actually leads us. So I think it is very important that if we need virtual tracing more as distal we go, and sometimes after fifth or sixth generation, around fifth or sixth generation, it loses its impact. So it's very important that we get ourselves, our brain trained in manual or hand-drawn bronchial branch tracing. It's a very good book from Dr. Kurimoto sir. And I think many of us who are interested in this should get learning and learn the nomenclature and how to do this on Radiant Viewer. I also use the same Radiant Viewer, and it works wonderfully when it comes for a manual or hand-drawn bronchial branch tracing.
Yes, absolutely. That's a good thought that both you and Bala have said, that we all need to learn how to read our CT scans well, trace it well, because even if you have these advanced visualization techniques, it's always better to be able to compare your manual and your only problem is that I know, that it takes sometimes 6 months to get absolutely trained. You rightly said that the nomenclature is not important, because I know what stops a lot of young people from doing it is because the nomenclature gets confusing. So instead of actually getting pedantic about labeling it correctly, you just start drawing it correctly. I think that is what is important,
ma'am.
what Bala has said. So moving on, Govind again. What is the importance of the concentric versus eccentric view on radial EBUS, and how will it determine the diagnostic success? I know Bala has already mentioned it, but if you could just tell us again.
Right. So as sir already explained about it very well in the presentation before, we have mainly the two views when we do a radial EBUS. That's a concentric view as well as an eccentric view. So concentric view basically means that your guide wire or your sheath is right into the center of the lesion, and it's evenly spaced out. When you have a probe around and you have a concentric lesion which is being seen, that means your probe is right in the center of the lesion, and this basically indicates that you have to go for a prompt biopsy, because the yield is very high in such cases, and the yield might basically space between somewhere around 70 to 80% of the times we can get a diagnosis in such cases. Whereas in an eccentric view, which is again one of the findings which we commonly do while we're doing a radial EBUS, the yield somewhere comes around 40 to 60%. The reason being that the probe is just at the outline margin of these lesions. So we might not be able to hit the lesion into the right time and in the right way. Most of the time, this is very difficult because the patient is breathing while we're doing the procedures. So the yield almost reduces to 40% to 60% in such cases. Very important thing what we need to know is, and clinical implication is, if we have a radial probe being doing and we see that the view is eccentric, don't just stop at that point of time. Maybe adjusting the scope a little front or back might give us a concentric view. So that is very important, because we might just be at one of the margin of these lesions and it might be giving us eccentric. So no point to be disheartened. We might have to adjust a probe a little bit up and down, and we might get a concentric image in such cases as well. If we are not able to do that, then probably using a fluoro is also going to give us a great help. And with facilities available, I think VBN and EMN can also be of a great help in such cases, particularly if the lesion is eccentric.
Okay. So, Bala, how easy is it for you to access cone beam CT when you are doing these? Not easy.
In my practice, so if I do a PPL, so 100% every case there will be a CM. There is no case till now. So you do a radial EBUS and without a CM. No. So there are many advantages. The first advantage is, see, just because the radial EBUS image is showing a concentric on eccentric doesn't guarantee you anything. The reason because, so unlike the EBUS TBNA, this is not real time. So you need to remove the probe out. So absolutely you don't have any idea when you're passing the biopsy forceps, absolutely you don't have any idea where the cup is opening, whether it is biting the mass or it's just the bronchial mucosa. Absolutely there is no input. So that's the reason fluoro, there is no option at all. First point. So that's the only option we can have because cone beam is not available in all the centers. Cone beam itself will cost 5 to 7 CR, and obviously it is shared by many departments. So to get a cone beam is not so easy. So I think we should use CM as much as possible. I do agree for less than 20 nodules, it is not so easy to get an image in the CM, but pretty good 20 nodules, definitely you can see the image in the CM and you can adjust in two planes. So whether you will biopsy forceps is inside the nodule or not, definitely you will have a better access. That's the first point. Second point, so when you're opening and closing the biopsy forceps, if you don't have CM, absolutely there is no feedback that the cup is opened or not. The many times you try to biopsy and you take it out, absolutely no material you can get. So you start using CM, you will able to see the cup which is opening. Definitely you can get material every time. So these are the two major advantages if you are doing radial EBUS for peripheral pulmonary nodule with CM. That's what I feel. Cone beam, till now I have not done any case because I don't have access to cone beam in my center.
Yeah, Bala,
Correct.
second one thing I want to add that with the our fluoro, because sometimes then our the rib images and all we can take a landmark because these are the fix, because I do agree, because when there is a cone beam is not there, but fluoro, then it can give us where your scope is there and where you have marked your lesion.
Exactly.
Yeah.
So most of the time, that's what Dr. Rakesh told. When the lesion is small and you're not able to depict the
See,
lesion in the CM, so the technique what we follow, that's what Rakesh was saying. So you mark the rib, whether it is just below the rib, just at the
absolutely.
rib, or the upper border of the rib, or
Or
lower
border.
border of the rib. So you mark that lesion because the length of the probe is already fixed because we usually mark the probe. Means I think it's pure technical because the length of the probe, the EBUS probe, we mark it at the opening of the working channel. So
Absolutely.
that length is fixed. So you have to be very sure that you don't jiggle the bronchoscope more once you fix the length of the probe and you mark the point on the CM. This is technical, probably it's not easily said than done. So this definitely there is an advantage if you are doing with a CM. So that's a very important point.
Right.
Great. Also, I think when you're using the thinner scope and you're not using the sheath, there again, because you have nothing in place, you don't know where the scope has moved, how much the length is moved. Again, the CM is of immense advantage. So moving on, again, coming back to you, Bala, is that do we always need a thin scope when we are doing radial EBUS guided PPL? Or
Yeah.
again,
So
it'll depend upon the location.
no, for me, if I'm doing a radial EBUS, it's always a thin scope first, never a therapeutic scope. Absolutely therapeutic scope. If it is an endobronchial, if it is in the main bronchus, if it is in the segment, so that's the second division. Probably you don't require EBUS at all. You just go there and get a biopsy. But if you want to go inside the subsegment or the segment, your thick scope is absolutely useless. And the problem here, because I've shown you the generation, the first generation, second, third, fourth, fifth. So let us think if your lesion is somewhere in the fifth generation or in the fourth generation, if your lesion is there, so your thick scope doesn't cross the second generation. Take it for granted. It doesn't cross. So after second generation, there will be at least 5 to 6 ways you can go
Visions.
to the fifth generation. So absolutely, you don't have any idea how to pass your EBUS probe to that fifth generation nodule. So 100%, if you're doing peripheral pulmonary nodule, I think that if you're stuck with a thick bronchoscope, it is very difficult. I won't say it is not easy at all. I would say it is very, very difficult. But your life is much easier if you use a thin bronchoscope. That's the 4 mm, 2 mm. That is the basic. I don't say everybody should get the 3 and 1.7, but definitely if you're starting a peripheral pulmonary nodule without a 4 mm, 2 mm, I should think that I feel that you should not start at all, because you will start losing cases. Once your yield comes down, so that's the very, very, very nasty thing to happen, because you will not touch the scope again.
Absolutely.
Correct. So important to have the right bronchoscopes first before you say, oh, my yield is not good because I don't have virtual navigation. Very important point. So, Govind, how effective is radial EBUS in sampling GGO opacities or subsolid nodules? I know there is data on it, but I mean, clinically, what is your experience? And then we can take it from the rest as well.
I think again, Bala sir quite wellly explained about this yield of ground glass opacities and subsolid nodules. So here we need to understand one of the basic things that a ground glass lesion or a subsolid, the reason why we are unable to get a good yield in such cases is because of the signal intensity. So just like how an ultrasound probe works, it works more of an signal propagation and signal receiving. So these ground glass lesions or a subsolid lesions, they have a very poor signal attenuation. So hence we will not be able to basically target or mark these sites very easily. There are data where they say in a subsolid lesion, if the solid part is more than 7 mm, the yield might be a little better, but that yield is not more than 30% or 40%. So in such cases where I have a ground glass lesion, and if this lesion is quite peripheral, I would always take help of my interventional radiologist to go for a CT guided biopsy in such cases, rather than losing this case or not getting an yield. So in my practice, if I have a ground glass lesion or a semi-solid or a subsolid lesions, I would rather ask my interventional radiologist whether he can access that lesion and plan to target it rather than going and chasing these nodules.
Yes, Bala, your thoughts?
To be very honest, till now I've never seen a ground glass opacity to do a radial EBUS, to be very honest, because we don't have a very robust lung cancer screening, or we get early lung cancers. I have only seen the GGOs targeted when I was for a short time at NCC Tokyo. So it is
Yeah.
very, very challenging.
The Japanese guys are very fond of it.
Yeah, so it's very challenging because there is a sign called blizzard sign. So where you see sudden increase in the signal intensity once you reach the ground glass. But I feel it is, I don't think I can pick it up. It's not so easy at all. So probably if you're having a subsolid nodule, maybe if you go to the solid lesion, probably you will pick it up. But to be very honest, till now I have never get a chance to at least try a ground glass opacity, at least to learn. Never got.
And second thing, then are the GGO, we don't know whether it's infective or what kind of a
Absolutely.
evolving.
100%.
Absolutely.
100%.
Sometimes in our immunocompromised patients also you get these, very peripheral GGO opacities. So somebody would want to extrapolate that and use radial EBUS to biopsy. Well, we don't know. So coming back to Jay, what are the roadblocks you've had in implementing a successful peripheral lung nodule program?
Ma'am, this nodule clinic program was very, first and foremost, it's very resource intensive. You need to have a armamentarium, plethora of armamentarium. Now, why I got an opportunity in my private setup was because of a new Philips Azuron cath lab, where we have inbuilt sentry suite. So once I got cone beam, then it became so much tempting to have this program in-house. Now the thing is that it didn't turn out to be as easy, because as Bala sir told, he has not used cone beam, but in our setup, endoscopy and most of the other setups also, the endoscopies are at different level, cath labs are at different level. So we are very much comfortable to operate in our endoscopy suite rather than in cath lab. So that is first challenge, that I tried to incorporate the CEM based therapy, that is body vision, which claims that any simple CM can be turned into this body vision or augmented fluoro CM. But unfortunately, our setup was not that advanced, where we had that advanced CM, which was fitting in their specifications. So otherwise, we would have got that CABT also, but it was not possible for us to get that. So that was first roadblock, and then we were doing the procedures like Bala sir told with a simple CM fluoro, and to do it in our endoscopy suite with the help of bronchoscope, thin scope. That is first requirement, as sir told. Now, what I did is I got wireless bronchoscope, because if you go upstairs in a cath lab with this many wires, so many televisions or monitors, then again it's a whole lot of thing and quite congested setup. So what I got is 4 mm 2 mm wireless thin bronchoscope, and it was having excellent quality of results. So that was one thing which we were able to do. That in our bronchoscope only, we were able to reach with the help of CM, as Bala sir told, with the help of Radial EBUS with a thin wireless scope, reach to the peripheral lesions, and we started getting biopsies and get acquainted to that. Now coming to the CBCT part, well, we get bronchoscope, Radial EBUS, thin scope, and cryo. Everything on fourth floor, and then there are ventilators. Most important thing is when there is spin, we need to go out to minimize the radiation exposure. So radiation exposure is very less when we are doing CM based procedures, and it's quite high even we are doing cone beam CT. So that was one thing where it was challenging for us. Even you will be surprised that bronchoscope stabilization unit itself is very costly, which we haven't talked about that. So it's resource intensive. But and not to mention addition of a cath lab charge, because you are, as sir told, it's a shared infrastructure. So I think every CBCT procedure takes at least 2 hours. So you need to add that charges too. Well, in bronchoscopy suite, we don't have to pay endoscopy room charges. So again, that adds into the patient's cost. So the challenges were maximal, but still we are able to cope that. But then there was a different challenge. Well, many people here, they are either thinking in terms of CT guided biopsy or a bronchoscopy guided biopsy. Now, to combine this is altogether a new concept, that CT guided bronchoscopy biopsy, lung biopsy. So it was very new concept. Even many radiologists didn't know that. Second is I met many surgical colleagues, surgical oncologist colleagues, and they were all very much surprised how a cryoprobe can take the sample. Because if you cryo that tissue or tumor tissue, then you will probably denature that. And it made great deal for me to make them understand that it's basically you get good piece, and only if at all you can denature, it is probably tuberculosis or some genetic material which you can denature. So, ma'am, from resource extensiveness to the infrastructure planning to the cost, from that to awareness among radiology colleagues to medical oncologist colleague to surgical oncologist colleague, it becomes like we are having one of the first nodal clinic program of our state, but still it's very much in the infancy. So cone beam altogether and having a good nodal clinic program is very tough, ma'am. And as you rightly mentioned, there are very few screening patients, very few lung screen patients. So that makes it difficult. But once people will understand that we can pick up stage 1, stage 2 patients more with this modalities, I think we are probably a bit early, but we are paving the way forward, ma'am. So this is a short story of our nodal clinic program.
Yes, Bala, what about you? Since you were one of the first ones to set it up in Southern India, what challenges did you have?
Basically, if this is very practical point I'm saying, because see, you want to do a radial EBUS, definitely you need that machine, you need that probe and all that stuff. So if I speak to my radiology colleague, whether if it is in the subcarinal, it is just near to the mediastinum, whether it is in the peripheral, he doesn't bother. He just does it in 10 to 15,000 rupees. So you just say, don't bother about all those stuff. You just send the patient with this, your job is done. And their success rate is more than 95%. So how can you compete with somebody who says that my success rate is 95%? And my cost is this much. So both ways, your radial EBUS fails. That's the greatest challenge I
Very
had.
practical, that kind of a way you accepted. Yeah.
So that's the one of the biggest challenge I had when I started the radial EBUS for nodules. But definitely, when you have a nodule, when you have a lymph node, definitely I would have told them we can combine all these cases. We can do a bronchoalveolar lavage, so not all nodules are malignant. We can definitely have benign cases. So definitely there is a role of radial EBUS because my charges were very low in when we started in 2015. So at that point in time, I was able to do some cases. So slowly it got picked up, but I don't have a definite nodule clinic because for that definitely you will require some kind of backup, oncology backup. Otherwise, you will never get those numbers to
So that
do.
would be easiest in a primarily oncology center. I think doing it in a pulmonology center becomes more challenging because you need so many things, and especially
Not
in the
simple.
private sector, each technique that you add on adds the cost. So as Jaykumar rightly mentioned, even the CM cost is added in some institutes. Forget the cath lab charge for the cone beam. It's also the CM charge that gets added. Then you add the cryo charge because the cryo probe now has become disposable. So it is challenging, yes, but there is a role for it. Yes, Aditya.
So, ma'am, I wanted to add one thing. When we are talking about the nodule program, we need to sit with our oncology colleagues and inquire that what is the problem, or discuss with them, because they rely more on the PET positive lymph nodes
Yes.
than the EBUS staging lymph node of the lymph nodes. So
Yes.
they regard their therapy, they about the treatment and everything. They regard it more superior. So we need to make them understand and then increase our input of the program. And one thing more, I was in Florence, so 1 month back. So I had the opportunity to see one more technology that is working in still in the infancy stage, the iris scope. It is a 0.8 mm fiber scope which enters all the way into the nodule. So it is also going to help more and more in the patients of the nodules, and the cost is very less if you are practicing more and more, because I can see that more and more patients are having the nodules. Still we don't have the means to encounter those kind of things. So more peripheral, more smaller nodules we can do with iris, but it is still not US FDA approved. So we can work towards that getting FDA approval, and then we can make it more popular in this country also.
Yeah, if you speak to the old timer oncologists, they will still refer for a CT guided biopsy, even for a mediastinal node.
Correct.
Forget sending to you for a peripheral lesion. They're probably not even aware that something like this exists. So I
Right.
think maybe it's time. I know all pulmonologists are convinced. Maybe we should have webinars for oncology colleagues because, I mean, our referrals also stem from there. So I think it is important for them to get convinced because I completely agree with Bala. If you compare cost and if you compare yield, sometimes you really have no answer when they tell you that your procedure is so expensive and you're telling me that your yield is at best going to be 60% in this patient.
And
I
also
mean,
the
what do you say to that?
and the
So,
time Jay was
and the
mentioning,
time that you're going to, yes, the time taken for the procedure. So,
and with a lot of uncertainty.
so with a lot of uncertainty. So yes, there are challenges, but with improving technologies, there is definitely a way forward. Govind, what is the current evidence and the various studies talk about combining radial EBUS and cryobiopsy for PPLs? I know Bala would like to have a cryo in his bronchoscopy suite, especially when he's unsure about what is happening on rows. But what do you say? Do you think it's going to be the norm? Because again, as I said, it's going to be another add-on cost for the patient.
So as rightly told, ma'am, the cost is going to be a great issue. And the disclaimer, particularly, I don't use a cryoprobe in radial EBUS right now because I don't have a 1.1 mm the probe. But what data has been coming off late over the last 8 to 10 years by multiple meta-analysis, including the 2021 Wang et al. Meta-analysis, it does show that the yield is around 76% in cases of a radial EBUS with a cryo, whereas in the radial EBUS, if it's a concentric lesion, again, the yield is around 70%. So the difference is maybe around 8 to 10%. But that's not the thing. I think it's more about the maintenance of the architecture and the pathology how easy it's for a pathologist to report these lesions, because when we take a sample from a cryoprobe, we know that the architecture is well maintained. And when it comes to the complications, I think the radial EBUS per se, if we use it with a forceps, it's somewhere around 3 to 6% of cases where the pneumothorax are being noted. And in cryo, again, it's around 6 to 10%, albeit the expertise of an operator who is doing it. But when we have bleeding as a major risk, be it a radial EBUS with a forceps or be it radial EBUS with a cryo, I think if we have an endobronchial blocker with us, probably the risk of bleeding can be managed well within. And if it's a pneumothorax, even then, we are pulmonologists. I think we are trained to put an ICD or a chest drain or a pigtail. So that should not stop us from going for a cryo probe. Probably it's going to be in the norm, but I think financial constraints are going to be a major factor. Maybe if the finances come to get down in the future, probably it's going to be a norm in cases of radial EBUS with cryo.
Yeah, I think the important thing here is to not tell people that if you don't have cryo, you cannot do radial EBUS. I think that is what is important.
Yeah.
And I think Bala had shown data from Kedar's center, which had good results, even equivalent results, right? With when they did
Yes.
use the cryo. And so I think it is important to realize that we rely a lot on data from the West, where they are not bothered about cost, they're not bothered about the financial aspects. Whereas in India, we do have to deal with those things as well. So I think maybe we should do large collation of larger, multiple center data even on this. Now that we have more and more centers doing radial EBUS PPL lesions. So Rakesh, coming back to you, are there any gray zones in the type of stents used in lung cancer? I know you showed 2024 data about, traditionally a few years ago, it was okay, you're only going to use metallic stents for malignancy when you're going to use stenting, but that's obviously not true. You've shown that data as well. So are there any gray zones about
Yeah, ma'am.
which to
So,
use when?
even that, because that recently the doctor, I think Udit Chadda, that he was the main for this. Then so I listened to him in the Kapi also, that in the Bangalore. So that because this the shift was it was done because earlier then the malignancy was just only considered as a palliative and to restoring the patency of airway. But now more and more that when our patients with putting a stents and then they are surviving more than 6 and 8 months or 9 months, then it become a stent become as a liability for you, because then it's now iatrogenic foreign body. So then you think then now whether it is required or not, and that's why then they start putting a concern that wherever then possible that if things are possible, like we can the stent can be removed, like a patient with the partial decan that your recanalizations with the around 50% of your lumen is and that still that obstructed, and then patient might respond to the chemo and radio, and then you put a kind in these kind of cases where your distal lumen is adequately addressed, that you can put your rigid scope and then adequately that open your silicone stent, provided that you have all the loader and then the device and tools with you, then you can consider the silicone, because its material is inert and you can safely remove it, because we have seen that now for last 8 or 10 years that majority of patients that you did not expect that with the metallic stent living, now I'm seeing the 2 year and 1.5 year patient is living and you're coming back because they lost to follow up, and then suddenly then you do now then your stent becoming, because they all metallic stent that get ingrown and then fractured and they perforate. So that's why then there is slight inclinations toward the silicone stent wherever the possible, and then your airway allows and the patient's conditions allow with your expertise and comfort with your setup. So ma'am, you are mute.
Moving to a discussion with your oncologist about whether you're going to give targeted therapy. This is an temporary means it's not like relieving breathlessness for end of life care. I think those things are the things that are going to be your
It's like
primary.
ACC and the carcinoid, it's very important. So like because I have seen that 3 patients last 1 year that ACC and just debulk and then send back to the surgeon, and then now they are doing good basically.
Absolutely. So Jaykumar,
Yes,
when
ma'am.
should stenting not be done?
Ma'am, this is a very important question. As in famous words, the best stent is which is not yet put. and hence I think it is very personalized decision whether to put stent or not. Some it's there is no randomized. There are not much studies, but I think this is case to case based selection. I'll give some examples of where I think the stents may work, like the sir has told, the malignant tracheoesophageal fistula, where you have to put stent, otherwise because of pulmonary sepsis, patient might not survive. So that is one clear-cut indication, but there are few cases, few exceptions. First is very advanced level of malignancy where the survival is less than around 1 month. So one of our patients where there were failed chemos, failed IOs, and they all told that she is not going to survive for around a month. In that case, we deferred putting a stent, although there was external compression causing central airway obstruction, and we fortunately could do so. And relatives also thank us that it happened in less than 1 month. Second was the case of anaplastic thyroid carcinomas. Now, these are basically very bad and aggressive type of tumor. Now, sometimes what happens if it backfires, sometimes your metallic stent migrates and you don't have tracheostomy backup. Then also it is very difficult. So this lady had very bad anaplastic thyroid carcinoma, which is inoperable. And then they had a significant respiratory compromise. First, it started with dysphagia, and then tracheal compromised. And again, it was in subglottic trachea. So there we deferred putting a stent. So this type of very highly aggressive tumor where you don't have backup, that was second patient. Third indication, very slow growing tumor. Like there was a case of RCC metastasis. The RCC was diagnosed in 2021, underwent nephrectomy. And then in 2023, the patient had right bronchus intermedius, which was not completely major airway obstruction, but a small airway got occluded and the IHC was suggestive of RCC metastasis. We did cryo debulking, patient went well. And then after 1.5 years, he came with only one complaint, coughing, that is dry coughing. So again, there was no breathlessness. We just did another cryo debulking and the patient was good. So in this type of malignant airway obstructions, although the obstructions are there, you can differ. Actually, if you put the stent, which is a foreign body, the patient will have again and again more and more coughing, and which may lead to stent-related complications. So you need to very carefully select your patients where it is going to benefit, whether you are palliating the symptom of breathlessness or preventing pulmonary sepsis or infections. One most important thing is that when you are putting SAMs, don't expect that you will get it out. I have recently come across certain stents where they claim that you will be able to get it out within 3 months, 4 months. I think when you are thinking of putting metallic stent, you should not think of getting it out because it becomes very difficult to get the stent out. So that is one thing. If you are planning that your IO or chemo is going to work and one day you are going to get this out, put a Skelicon because it's very easy to remove that. And one more thing is vocal cord palsy patients. Vocal cord palsy patients develop a lot of coughing, and then they have stent-related complications like stent fractures, sometimes stent migrations also, and again the tear of tracheobronchial tree. So I think the airway stent insertion has to be individual. It's very important decision. It has to be individualized in a case-to-case basis. And once you put a stent, I think there is very good stent card, which I think all of our cardiology colleagues are giving to many of our patients. We need to give this patient stent card, what dimensions, where we have put and what care to be taken, and we need to keep them under close follow-up. So I think that will summarize this answer.
Okay. So, Govind, any suggestions in which patients would you do a rigid bronch and just debulking and not put in a stent when there is central airway obstruction? Any specific conditions? You're muted, Govind.
I think particularly few indications, but yes, one is a large endoluminal tumor, and which is causing symptoms to the patient, that is a stridor. And we all know that to cause symptoms like stridor, the patient has to have at least around 50% or 60% of luminal obstruction. So in such cases, I think doing a rigid bronchoscopy debulking always helps. One, because it can restore the patency of the airway. Second, in such cases where there is a life-threatening respiratory distress, again, this is most of the time due to a stridor patients. And again, it ends up seeing that we have the patient of almost 50 to 60% of the airway patency being blocked. This is number one. Number two, I think in cases where we have a pure intrinsic kind of a lesion and we don't have an extrinsic lesion, as we all know, when we have an airway obstruction, it could either be an intrinsic, it could be an intrinsic plus extrinsic, or it could be an extrinsic lesion. So if it's just the airway which has a lesion or a mass and there is no extrinsic component to it, probably a good debulking by either mechanical, the APCs, the lasers, or combined efforts might even avoid us from putting a stent because the airway might be patent. And the only reason for in such cases to go for a stenting is if the wall is weak or if there is a collapse happening. So that can be seen by a rigid bronchoscopy while we're doing. So I think these are certain indications where rigid debulking itself can be therapeutic and we can avoid silicone, and where we know that the patient is going to respond well to a chemotherapy, like in squamous cell carcinomas. Though it's a slow response, we may avoid stent in such cases, and just a debulking might help.
So great. So I've been informed that we have 1,942 logins, and I think we are answering everybody's questions because there is not a single audience question yet. So moving on, coming back to Jay, what is CAM base? What is CABT, and how does it compare with the cone beam CT? You're on mute, Jay.
Ma'am, I think we covered in the previous question, I probably, but I think I will like to reemphasize that CAM based therapy, that is from the body vision, and which has a very good inbuilt real-time guidance. First, we need to load our pre-procedure CT into that so that we can get good airway mapping and virtual bronchoscopic navigation. And then on real time, we get this 2D vision and augmented fluoroscopy, which is very essential and important for tule lesion confirmation. The advantage of CABT is that we get it done in our endoscopy suite with keeping all our infrastructure preserved, and it has capacity to convert any CAM into the augmented fluoro arm. So I think we are very familiar with our endoscopy suite, and maybe within less charges we can give and offer very good yield also, because as sir told, we don't do radial probe guided procedures without any CAM guidance. So that is one more important aspect of CABT. To the proceduralist aspect, very less radiation is emitted during that, and hence we can be very safe, and also it is very fast. Coming to cone beam CT scan, so it's basically a CT where we need to go into the different types of procedures. First, we need to do isocentric of the patient, and then we need to do segmentation, mapping, putting breadcrumbs, and then finally we have a complete path and then tule lesion confirmation. Now, most of this happens in cath lab. So this cath lab has to be equipped with a sentry suit or a lung suit, and that software does all these things, including augmented fluoroscopy. Most important aspect is, or the limiting factor to us is that whenever a cardiologist operates, they operate from the side of the patient. When we operate from the head end of the patient. So you need to be very particular that your gantry is actually moving in a way so that you have very good isocentric of the lesion. So that is one thing. Second, it rotates very fast. So you need to keep as less wires as possible, and it emits a lot of radiation. So you need to have a bronchoscope stabilization unit. So that stand is we need to keep that, and I think when there are small lesions like 2 mm or less lesions, the lesions which are mostly affected by CT to body divergence, where you want inspiratory hold. Like there is lung navigation ventilation protocol, LNVP, when we proceed for cone beam CT guided biopsy, where the lungs are completely inflated with certain pressures, with anesthetist by our side, and the patient is in inspiratory hold. At that time, we have tule lesion confirmation and we get the biopsy. So this is the basic difference, where the location of the procedure being done, the patient selection, like 2 mm or less, plus the locations which are very much affected by CT to body divergence, plus where you need patient to be absolutely still. This all are things which will decide whether CABT or CBCT you will be able to go. And third is you need to go for the radiation threshold of yourself as well as your technicians. And final is, as ma'am told, cost implications of such procedures. So I think these are basic and fundamental difference between CABT and CBCT. And I think this will sum up the answer.
It's not all hunky dory. It's not just that when you have cone beam CT, everything is resolved for you. There are other logistic issues, other understanding issues of your ventilation, your pressures that you're using, how you have to be, a lot of other things also. So it's not like, okay, because your cath lab has a cone beam CT, you're going to start doing procedures there. And so that's an important thing. So coming back to Aditya, how would you choose your patients? I mean, is financial constraints going to affect your choice of procedure, or you are going to, because I know a lot of time it happens, as Bala has also mentioned, that if the patient is not very affording, then you are willing to take that risk of CT guided pneumothorax versus doing a radial probe guided biopsy.
It was very enlightening to hear Dr. Jay about his experience with the CBCT, the intricacies what he was talking, because when we are not doing those procedures, we don't know what is going on inside the procedure. So it was very enlightening to hear that. Now coming down to the cost, which is a very, very big constraint in our country, when you are talking about peripheral lesions, classic radial EBUS with guide sheath is the most economical if you want to use for a patient, because it is highly cost effective and very safe, and also significantly lower pneumothorax rates if we are using with the CR. But if we move a little ahead, we talk about EBUS, we talk about the needle walking in, cost increases. And those patients we are difficult to get when they don't have any backup with the panel or the insurance companies. If they walk in with the cash patients, the cost is around 40 to 50,000, which is very difficult to get from the patient in one go, to make the patient understand that you need this because it may be tuberculosis, it may be cancer. Then when you talk about CBCT, you talk about robotic bronchoscopy, the cost on the infrastructure, on your hospital as well as on the patient, it is very, very high. So in the Indian setting, the choice is often guided by the lesion characteristics of the patient and the institutional capabilities which you are working in. So traditionally, the Radial EBUS is favoring for the medium-sized bronchosine positive lesions, centrally located peripheral lesions, and advanced modalities can be more used for the small, difficult to reach, or the bronchosine negative lesions. So
Absolutely.
yes, it always affects.
So when you travel to one of these centers abroad, you feel like a child in a candy store, isn't it?
Yes, correct.
Yeah. So all of us have felt that at some point or the other, and you think, my God, why do I not have that? Why do I not have this? Why do I not have this?
Ma'am, it was like very overwhelming to see. I was in China in Ganjao University. Even you have been there. 80 interventions, 90 interventions going on every day. 18 OTs running simultaneously, and different kinds of intervention going on. Like I was, where do I go and see? Where do I stand? And then there's something else going on there. Somewhere lavage is going on, whole lung lavage is going on. Somewhere debridement is going on. Then rigid stenting is going on. So it's like overwhelming when you go there, because they don't have the constraints from the infrastructure. They have a lot in their kitty when they offer the patient, and even the patients are very obedient there. They agree to the doctor. They don't regard the doctor as money making machine. Even they are paying 40% from their pocket when they are backed up by the insurance companies around 60%. Still, it is a cost for them. And they come, they like a patient who was stenting was done, so he had to return around 1 week or 2 weeks again for the bronchoscopy. He was very obedient and he came for 3 bronchoscopies when I was there in 1 month, and got admitted and did the bronchoscopy there only. So these kind of patients is also difficult to find in India.
Also, their finances are not a problem, no? Like at least in the US, like in Cleveland Clinic, when I went the first time, I remember them putting in a stent, a rigid, they did a rigid bronch and they put in a silicone stent. And the stent, even though with their expert calculation and stuff, it kept migrating during the procedure. It was not fitting in. They just took it out and threw it in the bin. And I was like,
Another
hello,
stand
I'm
up, yeah.
standing here. Let me take it back to India. Like, let me at least show the people, like, okay, this is what it looks like. Let my students
Correct.
see what it looks like. So, like, it's so easy for them. They have a store which has all sizes, everything available to them, which is difficult for us. We have to plan, we have to look at
Ma'am, we
availability.
are
You have to
doing,
call up the
yeah,
supplier and say, is this size available? Is it not available? Right, Rakesh? You have to do all that
Absolutely.
background
Kind of
work. It's not like,
one of
okay,
my
you go and you
patients.
do the scopy and say, okay, give me this size, give me this tent, give me this, give me that. So I think just a shout out to all the young people there that it looks very fancy. But remember, it is
I've seen
always
the Tom
better.
Gilday because he has the same in the Cleveland Clinic. The Tom Gilday, then he was. So I think in Cleveland Clinic, the Tom was using this.
Tom, yes,
So
yes,
this
it was
I have
Tom
seen the
who was
same
doing
thing.
this. Yeah,
So
yeah. So it's not easy to set up. This looks very glamorous. Remember that maybe it is better that you set up one practice and do a lot of it rather than trying to set up everything at the
everything.
same time and work cohesively. Maybe refer to your friends, make friends with other people who have a modality available with them that you don't have rather than trying to get everything, because it's going to be a big financial constraint of you and if you try and buy everything together. It sounds very nice, oh, I want to have everything, but it's not practical.
I want to add also then kind of we need to understand that are the percentage of the patients and how many patients then we have that kind of volume that we
Correct.
need to understand that because then
Yeah.
first of all if we look for then our stenting things are there then first of all that we are still selecting our patient then how many of our patients require after debulking stenting we also kind of the categorizing them deselecting so they are not kind of first of all abundant they are not too much of rewarding they are not too much of definitive so we have to be very careful in terms of because our things are even we understand first of all twice or thrice we need to think so then the public will think about that yeah if somebody is offering me the something so it is not the equal to the cardiologist stents and all so definitely the cost because whenever then somebody you are giving the solutions not is a kind of a definitive or rewarding words are not too much of attached so then always then they will think about the yield and all and especially the diagnostic procedures where that your and then that diagnostic procedure is considered as a test so we are calling it as a procedure and
Yes.
That you fail the test and you pass in the test or not.
test exactly and then complication is considered as a failure so it becomes very difficult for that so we need to obviously we have to be in term of that very sensible that all things are replicable or not.
Yes, I think we should stop competing with each other and make friends with each other and say, okay, fine, I don't have this. Let me send it to somebody else who has the ability to do this. I think that is Rakesh and Bala, your wisdom talking with the white hair. I'm sure when you all were younger, you all wanted to do everything and say, oh no, I will put a stent. I will do everything in everybody, right, Rakesh? I remember you in your initial years. And so this is what changes as you grow older. You realize that, it's better to work cohesively than
Yeah, they all the procedures then you have done then come as a liability basically later on.
yes, yes. Okay, so any parting thoughts from anybody else? Jay, Govind, anybody wants to say anything?
So, ma'am, IP is
I think the
basically a
one thing
dependent
that I want
branch.
to just sorry. So that
Yes.
with the J that's they mention about the stent card, that is a very, very useful because I have prepared also in my language. So because
Yes.
when the patient's coming from the remote areas and somebody have unfortunately any kind of respiratory issues, anesthetists when they are intubating the patients, because I have encountered one problem that where suppose you put a stent in the proximal trachea and now somebody is ventilating or intubating, try to intubate and then they have an idea about that there is a stent it can come out with the tube and all so giving a card with this one that will make a decent idea so then he has some hardware into it.
Yes. So, ma'am, I was thinking about the IP basically is a dependent branch, as we all agreed upon that it's basically worked on where the onco is strong. The unfortunate part is that where these people are getting trained, probably we don't have that IP set up. And second is government schemes. Like government schemes cover PET scan, but it doesn't cover bronchoscopy or EBUS. So I think these two factors that when you are in your learning curve, when you are thinking that this patient is coming with a PET scan and then you are seeing the result, and you don't have EBUS facility in-house, like one of the largest institute in Gujarat, it doesn't have EBUS. It's an oncology institute, but it doesn't have EBUS. So linear EBUS or radial EBUS, any EBUS, it doesn't have. So it's the largest oncology producing institute of Gujarat. So once you are having all trainees getting out from those institute where they don't have that referral, they
How do
have
you
very
expect
less
them
trust
to
in
think about?
referring and experimenting something new in their own practice. And second, once they are having the same data, probably which they rely more during their training days, which is covered under Yojana, under some schemes. So I think these two aspects we need to address as a just community. And if we can make difference there, I think we can get more bulk of IP, interventional pulmonology patients. I think that's what I was thinking to generate the diagnostic as well as staging procedures and interventional pulmonology procedures.
I think
Yes.
then kind of so I think other people will agree or not. So even then the EBUS procedure is not considered in the our insurance. Then sometimes it get rejected because so it's difficult
Diagnostic, yeah, because it's just a diagnostic test.
diagnostic
Exactly.
test.
Yes, yes, Bala, your parting thoughts.
Yeah, so I feel that the easiest, I feel it's the cheapest, I should say it's the cheapest one. So everybody should start doing Radial EBUS whenever they have access to do it, because you'll really enjoy Radial EBUS, because that's what I have. This
Mhm.
2014-15 was when I started doing Radial EBUS for the first time. So I enjoyed more Radial EBUS than EBUS TVNA. So EBUS TVNA was never fun to me because it's just like seeing the lymph node, just getting it directly. But doing mapping and going getting the lesion, going getting the nodule is really challenging. And for a fresher, definitely you will have very good time to spend. Again, when you choose the lesion, I feel when you're starting, at least don't choose less than 20 mm and choose a bronchus sign. Use a CM, use a thin scope, and with minimum cost, you can get a diagnosis. Majority of the times, 80 to 90% of the times, you will get a diagnosis. And you don't have to have fancy equipment all the time. VBN, CBCT, not at all required. Especially when I told you the lesion sizes are 20 and you have a bronchus sign. So definitely in those cases, you don't even read a guide sheet also. The cost is also come down. Just use a regular biopsy forceps, a CM, and do manual mapping. Doesn't come at any cost. Use a DICOM viewer. No cost at all, zero cost. Only cost is your time. Another 15 minutes time it will take to draw that map. So once you draw the map and go to the lesion and get it, once you start doing manual mapping and targeting the nodes, definitely you will improve yourself slowly, step by step. Definitely you will improve yourself. That's what I feel.
Yes. So I think at one of the institutes that I go to, it's a teaching institute, and we have Radial EBUS, but we don't have SIAM. So we have that challenge, and I think it's the same. It was the same with PGI also. For a long time, they had advanced equipment, but they didn't have SIAM. So I mean, it's challenging, but yes, we choose our patients wisely. Time spent, I think, is the most important. Okay, how if you don't have time and if you don't have patience, please don't do these procedures. You have to give time. So if there is lack of time, especially, so as you're saying that when you are early on in your career, when you have more time, it is a good time to learn. And if you have the availability of these procedures, uh, the one thing that I do tell the students at KEM where I go is that we are starting to do bronchial tracing even in simple non-malignant lesions, just to get them tuned to the idea of how to look at it. It's not necessary that we do it, just so that they get trained to the idea. They look at radiant DICOM images for every patient, and they trace even when they want to do washings for say simple infection. I tell them that you start tracing so that you get trained for it, because as you said that our numbers for malignancy may not be as high, but once we start looking at all patients as potential patients, said understanding bronchial branch tracing will become much easier and your yield will be much better. Yes, Aditya, any parting thoughts?
No, ma'am, the same thing which you were talking, bronchial branch tracing is a very good practice which can be incorporated in the curriculum if they are taught from the PG days. That not much time is spent, only 15 minutes, and you start getting the hold of it. And when you come at like Dr. Bala's place, so you are very easy with the verse of making, and you put it in the regular practice that you do make it, and that makes your work very easy.
I think, in this forum, I'm the perfect example. I learned everything myself. like pretty much most of it was observed, self-taught. We didn't have training programs which taught us all these things. I mean, you all have had the luxury of going to this thing. I went to these programs much later on in life. But I think it's important that these students have this available to them. They should definitely learn and they should be trained in the right direction. Yes, Govind, any parting thoughts?
Yeah, ma'am, I think as we all know, most of the referrals for us come through the oncologist and the other physicians from side. So I think training them or educating them that this is what we can do is very important, because when I came to this part of the town of my place in hometown in North Karnataka, we didn't have EBUS. So we didn't even have linear EBUS to start with. So I think educating them that we can do these procedures, get a diagnosis, get a yield, help them in their treating their patients well, is something where we all start from. And for all the beginners, I think this is how it starts. The age might be different for anyone, but I think everyone has to go through this learning curve, and probably with time they're going to gain more patients and more procedures in their career.
Yes. So great. I think we have really overstretched. It's 10:05. Thank you, everyone. Thank you,
Thank you.
Bala. Thank you, Rakesh. Thank you, Aditya. Thank you, Jaykumar. Thank you, Govind. Thank you, CCI, for having us here and for giving us this opportunity. I'm sure it's been immensely successful. Thank you, everybody, and looking forward to seeing everybody on 22nd to 24th August at CCI Con in Calcutta. Thank you.
Thank you, ma'am.
Thank you so much.
Thank you so
Thank you.
much.
Good night.